Hello, everyone.
Good evening, welcome. So let us now start. Shreya, the slides, please. A very warm welcome to all of you to this 190th edition of Thursday Musings. Seems to be we'll be able to make a double century. And today the topic is on a time-tested gold standard drug. So topic of today is spotlight on lithium use in bipolar disorder. What is the current status and what are the best practices? And we have a specialist speaker to speak on this today. Next slide, please. I'm starting the session, and as soon as Tofan sir joins, he will take over the session. Dr. Tofan Pati is the chairman of this program. He is from Cuttack. Next slide, please. Dr. Amrit is out of country on an official visit. I welcome Amrit in his absence. Next slide. You all know me. Next slide, please. Thank you. Aleem from Lucknow. We welcome Dr. Vishal Chabra. He is our co-moderator for some time now, and he is doing all the hard work behind the screens. Thank you, Vishal Bhai, for joining us. Next slide, please. Let me introduce the chairman of today, Dr. P. Krishna Mohan. He is MBBS from Siddhartha Medical College, Vijayawada, and DPM from Guntur, and MD from KMC Manipal. He has a huge work experience in his private practice, 1994 to 2004. He joined uh, PS Medical College as assistant professor and currently he is professor and HOD there. His area of interest is psychopharmacology and mood disorders. Next slide, please. Welcome, ma'am, Dr. Aarti Behel, consultant psychiatrist at Apollo BGS Hospital, Mysore since 2004. She is MBBS from Thanjavur, MD from KMC Manipal, and PGD MLE from Bangalore. Previously has worked as assistant professor in KMC Manipal for 2 years, presented 6 papers in national international conferences, has 2 book chapters. Her special interest is mental disorder in women, OCD, medical legal aspects of psychiatry. So now the stage is yours, respected chairpersons. One of you can introduce the topic, other one can introduce the speaker. And the next slide, please. So someone can introduce Dr. Ramandeep. Next slide. Over to you, sir.
I'll introduce Dr. Ramandeep and then Sir can then introduce the topic.
Yes.
So Dr. Ramandeep, she's a professor at the Department of Psychiatry at prestigious AIIMS New Delhi. She's from GMC Patiala, her MBBS and her MD Psychiatry was from AIIMS as well. She has had a huge experience in clinical teaching and training of MD residents and supervision of MD thesis. Over 100 peer-reviewed publications and 30 book chapters and co-editors of 4 books. She's also won the ICMR Tilak Venkoba Rao Award in 2017. She's been the investigator-in-chief, investigator and co-investigator in a lot of other studies. Her areas of interest are bipolar disorder, suicidality, lithium response, and clinical psychopharmacology. I welcome Dr. Ramandeep to initiate the session, but before that, I would request Dr. Krishna Mohan to go ahead and introduce the topic.
It's good evening, all of you. It's good to have Dr. Ramandeep, who is interested in lithium and also bipolar disorders, the vast experience in clinical psychiatry. As all of us are aware that lithium is a gold standard molecule, even after 70 years after its introduction, 75 years. And it is still a #1 drug in mood disorders, first line choice by various national and international bodies recommend lithium as a first-line drug. But of late, people are worried about its renal toxicity. The one should be aware about it. The part and parcel of treatment of bipolar disorder with lithium includes educating the family and the patient. That is most important than just prescribing lithium 2 tablets a day or 800, 900 milligrams a day. So patient and family must know everything about lithium. And it's a wonderful molecule. It reduces the cycle frequency, number of episodes are less, severity is less, and is known to be a drug of choice in euphoric mania. It's all known to all the speakers. So we'll listen it from the expert, today's expert, Dr. Ramandeep. Over to you, ma'am.
Thank you, sir. Thank you, ma'am. I hope my slides are visible.
Yes, ma'am.
Okay. So in this session, let us put a spotlight on lithium and its relevance and role in the management of bipolar disorder. Now, while the slides will act as a stimulant to the discussion which will follow, and it's not possible to cover everything about lithium in 45 minutes or so, but I hope, especially for the early career psychiatrists and the residents who are in the audience, to take away the ongoing and reinvention of lithium, which has taken place with each decade since its existence in the medical sphere. Now, broadly, if we see the seminar topic, there are many questions which arise. One is why to use lithium, when to use lithium, and how to use lithium. Now, overall, if you see the evidence, it is more and more, especially in the last 2 decades or so. Now, in terms of the practical management, however, while all of us do use from, to a varying degree in our clinical practice, and I do use it a lot. But while preparing for this 45 minutes talk, I realized that the practical management of it probably can come in the audience questions, or maybe at some time as an independent seminar in itself. Because how to use lithium optimally is, and in terms of monitoring lithium toxicity and all the psychoeducation which should go into it, is a separate topic in itself. So essentially what we will focus on is the evidence and best practices on when to use it and why to use it. Now, the word lithos in Greek means stone, and this is because lithium was discovered from mineral ore, and the name is a tribute to its geological occurrence. It's widely distributed in the Earth's crust. In fact, it is much more common than lead and some of the other common elements. And why this is different is because the other alkalis in the same group, for example, sodium, potassium, they are largely plant-based alkalis. So this is the pink colored petalite mineral ore from which originally lithium was isolated. Now, if we trace the history even further, one can say it's a 13 billion old drug, because it was formed immediately after the Big Bang, along with hydrogen and helium. So essentially what we are using today is part of the primordial dust from which everything in the universe formed. So this is the periodic table, and it has a very unique position after hydrogen and helium. And both of those are gases. And so lithium is it has several unique atomic, physical, and chemical properties. Of course, it's the naturally occurring alkali metal. The other two are non-metals. It is the lightest solid element, and its atomic mass is around 7 or so. If we see its physical properties of the elemental lithium, it is very soft. It can be cut with knife, and it reacts very vigorously with the water, very low density, and can float on almost all the light hydrocarbon oils and even water, though it reacts and therefore often is stored in oil. Now, in lithium, in nature, is found in essentially two isotopes. Lithium-7 is what is more abundant and what is more discussed about. And the relatively less common isotope has other uses. For example, in fission and in hydrogen bomb, etc. The element lithium traverses, of course, way beyond medicine and psychiatry. The overall world production of lithium, as we know, largely goes into all the rechargeable batteries and even some of the non-rechargeable batteries for clocks, etc. And the medical consumption is less than 2% of the overall lithium which is extracted. All of us are aware about the pharmacokinetics of lithium. It is very well absorbed orally. The citrate, which is a liquid form, is even better tolerated. But in India, lithium carbonate is more common, is the only form which is available. And it is well absorbed and reaches well absorbed in and for an immediate release preparation in about 1 to about 3 to 4 hours for sustained release preparation. And it is mainly distributed in the water, the total body water. And we know that it does not undergo any metabolism and completely eliminated unchanged through kidneys, though a very, very small portion is also excreted through other ways, including sweat. It has a very narrow therapeutic window, and there are many, many factors such as body weight, the fat-free mass, the renal function, and the various interactions, and even the consumption of the certain food, for example, the salt intake. Such that a very, very close therapeutic drug monitoring is justified. Now, when we see the half-life of lithium, with respect to the neuropharmacokinetics in brain, it is much more on an average 28 hours, which is higher than the serum half-life of about 14 to 16 hours. So lithium is released much more slowly from the brain into the blood, and this has implications for it has many clinical implications, especially when the lithium levels are higher and in the toxic range. With the newer techniques, especially the lithium MRS imaging, we can now know the brain concentrations of lithium, and it seems to be unevenly distributed across the brain. We don't have this as of now in India, but in the next 6 to 12 months, it is expected that in India also, we will start using regularly. And the brain concentrations for maintenance at least for the research purposes, the brain concentrations for the maintenance treatment in bipolar patients vary between 0.2 to 0.3, 0.4, so much lower than the serum levels. The mechanism of action of lithium, as it is a key which open many locks, and there are many, many hypothesized mechanisms, and no one knows for sure, but the most robust contender is the GSK 3 beta inhibition, and along with PIP2 pathway, as well as the G protein modulation leading to neuroprotection, long-term neuroplasticity, and other downstream changes. Now, a normal adult human body, an average weight human, has been found to have about 2 milligram of lithium. But there is no deficiency states, at least in the humans. But in the animal studies, especially in rodent models, deficiency states have been described, including rodents which die early, which have accelerated aging, and which have many cognitive deficits. But as far as humans are concerned, there is no known definitive biological role which is established as of now. Though if we see the parallel research from the nutritional side of it, the low dose of lithium as is proposed as a nutraceutical or a supplement. So more and more people though there is no well-established research, but they hypothesize that probably the role is not discovered or established yet, and micro doses could have some biological role, which is as of now undiscovered. a standard 300 milligram tablet has about 8 milliequivalent of elemental lithium. Now, this 8 milliequivalent is about 55 to 56 milligram of elemental lithium. Now, there are many milestones which historically have led to lithium being used, then forgotten, then rediscovered, then fell out of use, and then again it keeps on emerging as a renaissance drug. Something similar to this movie, also a recommendation. But lithium has had a very complex, non-linear kind of narrative. And if we discuss the story of how lithium emerged over the last 150 years, and lot of researchers who contributed, not only Cade, but many researchers before him and after him as well, that is a separate narrative in itself, which will take half an hour or so. So we will skip through most of that, but highlighting the landmark events. Around 1800, this petalite ore was found by a Brazilian student who was a metallurgy student who worked on a Swedish island. And there, on a study tour, he discovered this new ore. And soon he sent it over to entire centers all across Europe so that a pure metal or element can be isolated. And the next few decades went into the efforts using electrolysis and various other methods which were in fashion in that era. And finally, by mid-19th century, the pure metal was isolated in a more consistent and reproducible manner. And soon, by 1859, we find the earliest reports by Garrod, who used lithium for gout. The uric acid diathesis was the prevailing hypothesis of the time, whereby it was felt that lithium, if used in patients of gout, can lead to the urine becoming more alkaline and promoting the excretion of the gouty crystals. And gout was frequently associated with depression or melancholia, often referred to as gouty melancholia or gouty insanity. And Garrod used lithium for this gouty melancholia. And in 1871, Hammond, many decades before Cade, used it, the bromide salt, lithium bromide, in the treatment of acute mania. However, the doses which he used were about 4 to 5 times higher than than what we know now to be the therapeutic dose. And therefore, though used in in many of his patients, but probably many of them had lithium toxicity, and within few years, he more or less had stopped using it in the usual practice. And then came Lange brothers. The Lange brothers both were physicians, pathologists, and had extensive practice. They used it extensively in periodic depressions. And by 1900, however, the medical use fell out of favor. Many researchers of that era criticized it, including Kraepelin, and who did not find any basis, including any merit for uric acid diathesis, and largely abandoned the use of lithium. Now, it is also of interest that in the last 5 to 10 years, 2010 to 2020, if we can see again a resurgence of interest in the uric acid hypothesis of and with meta-analytic evidence suggesting probably some kind of role of uric acid. Now, Lithia water, of course, continued, and we know the 7-up of the 7 things which were found in the lithiated 7-up water. One of them was also a very low dose of lithium, and the word up refers to the mood elevating properties which were associated with the drinks. It was also used as a substitute for common salt in patients of hypertension, and soon toxicity reports emerged from America especially, and thereafter it was largely banned and fell out of favor. However, this decade also coincided. By end of this decade, John Cade, while working in a very remote hospital in Australia, rediscovered the use of lithium in acute mania through a series of coincidences. It was a serendipity coupled with astute clinical observation by him. He thereafter tried it on 10 manic patients, of which 6 recovered very soon and could be discharged from the mental asylum. The research evidence was later established by Mogens Skau, Bastrup, and Hartigan, who conducted very, very important landmark studies, including the controlled trials, which laid the ground for gradual acceptance of lithium. But that was only the beginning, and then they had to face a long battle, especially to get its approval in USA. While the use was common in European countries for 10 to 15 years, but the FDA approval required a double-blind RCT, which was not available till 1970 or so. And most of the leading journals of the time dismissed it as a therapeutic myth. And that led to the first double-blind placebo-controlled RCT by Bastrup and Mogens Skau. And that led to finally a gradual acceptance in US and FDA approval in 1970 for acute mania. And a few years later, the use and the approval was extended to prophylaxis as well. It is also very peculiar that lithium can't be patented, and therefore there was no commercial interest by any of the pharmaceutical companies. Finally, a task force was constituted, and it was thought that FDA will constitute a committee and they will themselves conduct trials all across the willing psychiatrists who had put requests to permit the investigational drug use to benefit their patients. And it was at that time that 3 different pharmaceutical companies, mostly as an outreach, not for commercial interest, but to be able to contribute to the cause, they came up and took up the further research studies which were needed for approval. And thereafter, after the anti-manic effects were established, then prophylactic effects were established. The antidepressant properties were also soon, became noticeable, but the approval for bipolar depression did not come through. In the next 2 decades or so, the anti-suicidal properties of lithium began to be seen and also documented in research studies. And by turn of the century, the first report, which was published in Lancet on increased gray matter volume, about 3% increase in gray matter volume, led to a new spin to the neuroprotective role. And very recently, in chemistry side, the lithium batteries and the 3 researchers who contributed to it got the Nobel Prize. But because of a very long history of lithium discovery and rediscovery, which spanned around 150 years, and a lot of people contributed, also probably there was no commercial interest, it was not patentable. So while it saved a lot of lives over last half century or so, but as of now, it is a Nobel drug, but not a Nobel Prize winning drug. Also, in 2002 onwards, there has been a renewal of research interest, and we see the evidence mainly from the academia and from the non-funded groups. There is also an international group on study of lithium, IGSLI. So we see a renewal interest from self-driven researchers all across the world. And one reason for renewed interest is a faith that lithium probably carries the key to unlocking the pathophysiology of bipolar disorder, at least in a subset of patients. So now there is an anomalous association between the data which is available for lithium and a downward trend in prescriptions which carry lithium. Now let us see how commonly it is currently being used. Now this is a review of 55 studies which were available till 2020 with lakhs of patients across both OPD and IPD setting. And we see they took a cutoff year from as a median cutoff year. And it was 2010 for America and 2003 for Europe and Asia. So we see in the pre and post cutoff years, there is a dip from 27 or 28% to 17% in North America, while the use has more or less been stable across Europe as well as in Asian studies, which is around 1/3 to 1/4 of the prescriptions. Now, cross-sectionally, if we see the most commonly prescribed medications in the global bipolar cohort sites were the mood stabilizing anticonvulsants, closely followed by second generation antipsychotics, and lithium retained about 1/3, that is around 29%, 30% of the prescribed medications. Now, if we see the Indian studies, most of which have come from tertiary care teaching institutes, the use is around 30 to 40% of the long-term remitted patients. But we know that the use varies a lot depending on the setting and depending on the region. The use is much higher in bipolar type 1 disorder compared to bipolar type 2 disorder. And the data also points towards that across all the sites. Now, this is the 20-year trends of prescription, and lithium is in the gray line. Now, while there is a steady decline from mid-90s onwards, but if we see the last 1 decade, that is the last 5 time points of successive 2 years, 2007 onwards, the use of lithium has more or less been stable, and that is reassuring. It probably means that lithium has found its niche role and is consistently used at least in somewhere between 20 to 25% of the patients, depending on which country the practice or the prescriptions are looked at. And the use can be as high as 30 to 35% if it is a European country. And of course, it is much lower in America. In Scandinavian countries, out of the general population, for every 1,000 people, at least 2 are on lithium. And they have received at least 1 prescription for lithium. So it is 0.2% of general population, and the similar is equivalent rates in Australia are 0.3%. That is 3 in every 1,000 adults above 50 years. The use, interestingly, is in younger age groups is less, but as the age progresses, at least over the adult lifespan, the use increases. And this is this can be seen from Canada. Both the graphs are can be superimposed on each other. The x-axis is the same, and we see between 18 to 24 years the use is much lower, while the use in females, the older females, 50 to 64 years, is almost double compared to the younger age groups. One major reason for underutilization of lithium is, of course, the advent of the newer drugs, both for acute care as well as prophylaxis, which is a welcome thing in itself. The SGS are increasingly being used for acute episodes because of their faster onset. And also, they are being used for milder illness courses, even for prophylaxis. In fact, if we see the sales of second generation antipsychotics, their use in bipolar disorder is much more common compared to the sales are more for bipolar disorder compared to even psychosis. The pharmaceutical campaigns also emphasize newer drugs and sometimes skew the prescriptions. One good example is valproate, because when it came in early 90s, mid 90s, it was increasingly pitched against lithium for its role in rapid cycling, for its role in mixed symptoms, etc., even though there were no head-on comparisons. So, the uh, some of the indications which is in all our minds uh, uh, associated with valproate or carbamazepine, there was no robust evidence in at the time when those indications were heavily marketed and promoted. Also, there are potential medico-legal concerns, and there is a defensive practice, especially in the Western countries, but also more and more so in lower and middle-income countries as well, including India. One major reason for underutilization in US is the US is probably the only other country other than New Zealand which has direct-to-consumer marketing, and so it carries advertisements of various newer agents all over the media, both print media as well as over television. And so this direct to consumer marketing also leads to a lower utilization of older agents and more reliance on the newer agents, even though their efficacy may or may not match lithium. So overall, if we see on a positive streak, lithium continues to be still used in at least about 30% of prescriptions, and though it is a little lower in America. After an initial decline, the use appears to be stabilized in the more recent decades, and the use is higher in type 1 disorder compared to type 2 disorder, but it varies across the settings. So, stating the case for lithium, why there is a need for spotlight on lithium? So, first thing is lithium is a class of its own. If we see anticonvulsant mood stabilizers, there are many in the class, and same with second generation antipsychotics. Every 5 years or every 3 to 5 years, a newer agent gets added. But lithium, as of now, is a sole agent, and it is a class of its own till date. It has proved its mettle in spite of no resources, no marketing, and no patenting associated with it. Many of the unique properties of lithium are not shared by other drugs which are available for bipolar disorder. And if we see the RCTs in the last 2 decades, lithium has often been used as a control or a comparator drug. So it is essentially a benchmark against which other drugs are tested, if not placebo. Also, it has a certain specificity to the illness course. Unlike other agents, the use of lithium is very specific to bipolar disorder. And the only other related conditions it is used in also raise a suspicion, for example, in unipolar depressions, when it is used, whether there was an underlying bipolarity to it. Also, while we see lithium getting replaced, at least in some areas, by second generation antipsychotics, but that is as a category. No single molecule has been able to replace lithium. Rather, it has been raising its own bar. So what are the arguments for using lithium, and what is the evidence? The first is, while we are managing the bipolar illness, it is not the acute episodes. It's not the short term we think over. We know it is essentially a recurrent illness in 80 to 90% of individuals, and it is only the fortunate 20% maximum. And many studies say it's around 10%. But it's a very small proportion who have a single episode, and a very small subset overall who have a low pressure of illness, who have episodes which are spaced by a decade or many years, and who have episodes which remit naturally. For a large number of patients, median time to relapse is around 1.5 years. And of course, by median, it means for about half, the relapse is much more earlier. And overall, 60 to 70% relapse within 3 years. So while many drugs can serve as quick fixes, but they, generally speaking, don't replace lithium for the long-term prophylactic benefits over the course of the illness. Now, why to give prophylaxis? Again, the case is already laid because the first episode typically happens at a median age of 23 years. About half of the people with bipolar disorder, more than half, will have illness onset when they are below 25 years. That is the time when they are having their education, they are setting their career, they are probably getting education as well as a career, as well as marriage and other things. So each episode leads to dysfunction and loss of a precious year. And also, the episodes typically relapse within 1.5 to 3 years in a large majority. And there is no way to know who will relapse and who will not. So from a statistical perspective and from a large population data perspective, it makes sense to cover the patient for prophylaxis, especially if the episodes have been moderate to severe. The current guidelines, including CANMET guidelines, essentially seem to suggest that after the first episode, prophylaxis is the norm. And there is no provision, unlike before, to stop the prophylaxis after 2 to 3 years if it is only a single episode. The current guidelines seem to suggest prophylaxis to begin as early as first episode. And some of the rationale which is also given is that each episode leaves footprints and may contribute to some amount of neuroprogression, deficits, or even kindling. And so rather than treating the episodes, it might make sense to prevent the episodes, especially if the patient agrees and if the episodes carry a certain severity and risk to it. So if we see the bipolar illness, we treat the overall illness course and not the episode by episode. And from that perspective, it makes sense to choose a drug which also covers better for prevention. Now, while lithium was being used, valproate came in 90s. And there was really a debate on which is better over the other. And there was no randomized trial to compare lithium and valproate till this balance study. So balance study essentially is a landmark study in itself because it established the prophylactic superiority of lithium over valproate when used as monotherapy. And it is also to say that the combination still worked better than either of the monotherapies alone. But when used as a single agent in itself, lithium performed superior than valproate in balanced study. And it had a reasonable sample size and a reasonably long follow-up period as well. Now, most of the clinical practice guidelines, including CANMET, has lithium in the first line treatment. If we see lithium along with quetiapine are the only two agents which have all quadrants of the circle green. So they have a robust efficacy for prevention of any mood episode, depression, as well as mania. And as far as safety and tolerability concerns go, both are more or less equal. Quetiapine has its own set of problems, and lithium has, of course, a narrow therapeutic index, etc. So there is no clear superiority between the two. If we see the other practice guidelines, and this is a systematic review of all the other major 5 practice guidelines, all of them have lithium as the most effective mood stabilizing agent. And if we see again, this is the table which shows lithium across all the guidelines. Now, not only the head-on comparison with balance study and guidelines, if we see lithium carries a good amount of evidence from naturalistic cohort studies. And this Kessing et al. Had a recent systematic review of all the observational studies which compared lithium versus other mood stabilizers. And a total of 9 studies with 14,000 plus patients were included. And it was concluded that maintenance lithium as a monotherapy had better outcomes than any other monotherapy. And that included valproate monotherapy, but also lamotrigine, olanzapine, quetiapine monotherapy, among other agents. Now, the monotherapy with lithium survived the longest without relapse. So about 2 years for lithium monotherapy as compared to less than 1 year for quetiapine monotherapy, as we can see from this curve. And this is based on a separate study from UK. Now, when we see only the placebo-controlled studies, now this is the network meta-analysis, and the sheer quantity, the sheer number of studies, the two nodes which are joined in the center, the thickness of the line reflects the number of the studies. And we see the line is thickest for the nodes which connect placebo and lithium. And overall, lithium was concluded to remain as the first line treatment, notwithstanding, irrespective of its tolerability. And this is again from the same network meta-analysis. Lithium tops the list. This is a color-coded hierarchy, and lithium is at the top of the hierarchy with more than 1,000 patients as compared to rest of the drugs which had less sample size, but also lithium was the only agent to have statistically significant differences in all the phases, and also with reasonably good confidence for the relative risk. The other agents either had some of the phases which were statistically non-significant or had did not have enough confidence for the relative risk. Now, another thing associated with lithium was that not only the quantity of studies, but also the quality of study was more robust. 17 out of the 19 lithium studies did not use the enrichment designs. The more newer molecules, especially quetiapine, all of the trials had enrichment design. Essentially, enrichment design favors continuation of an agent in people who had already responded to that agent. And all the quetiapine studies also were industry sponsored. So while still quetiapine has a robust amount of evidence, but the evidence does not surpass in quality as well as quantity with lithium. The real world, the third set of evidence comes from the real world hospitalization rates, and all cause hospitalization was lowest with lithium, while quetiapine showed only modest effectiveness in reducing the readmission rates or the rehospitalization rates. And after the sensitivity analysis was done, the consistent benefits were observed only for lithium. And the similar data from real world setting is also available from Swedish cohort study, again a large data, where lithium was associated with lower rates of readmission as well as lower suicide rates. So lithium is also not an ideal mood stabilizer. We know ideally a mood stabilizer should work on all 4 phases, acute and prevention of both mania and depression, and now also mixed and rapid cycling, etc. And none of the agents, including lithium, checks all the boxes. And the operational definition is that it should work for at least 12 months, though clinically, of course, we would want it for much longer duration. And also, if we see, apart from lithium, quetiapine is the only other drug which has both acute and prophylactic efficacy in all the phases. And lamotrigine is lamotrigine largely has evidence towards the depressive side, both for acute and prophylactic efficacy. So another question is whether to give monotherapy or whether to go for combination. And all of us, especially in the hospitalized patients, in patients who are more severely ill, who have to be admitted, a combination is started more or less as a rule rather than as an exception. But all patients don't need to be managed in IPD settings, and a large majority are managed from outpatient basis as well. So this particular study by Kishi et al., this was a meta-analytic evidence to investigate the question whether mood stabilizer to be given alone or in combination with a second generation antipsychotic. And it was seen that after a period of sustained remission, as long as a year, once the second generation antipsychotics were discontinued, the recurrence rate was much higher. While if both agents were given together, the recurrence rate was much lower, as seen in the black line. So the maintenance with both had lower rates, and discontinuation of SGAs had typically almost double the rates of recurrence. And this was true not only for any mood episode, but also was seen for both polarity episodes. So this meta-analysis concluded that recurrence rates for mood episodes did increase after SGA was discontinued, and appeared to suggest that both a combination probably helps better. But the caveat is this meta-analysis carried studies only for patients who initially got better on the combination. And so this data is not generalizable to patients who responded only to one mood stabilizer as a monotherapy alone. So who is an ideal candidate for lithium prophylaxis? Historically and in our traditional teaching, these are from a conceptual standpoint, these are the 5 main descriptors which were given for an excellent lithium response or a very good lithium response. The first is the classical bipolar. So the symptoms description, euphoric mania, the Kraepelinian MDI. The second is a recurrent illness with full remissions, full complete remissions in between. Individuals with family history of bipolar disorder. So family clustering of mood disorders, but also specifically bipolar disorder. And absence of any psychotic symptoms or absence of any schizoaffective kind of presentation. So traditionally, these were the patients who were considered the ideal candidate for lithium. However, we know there are a lot of recent nosological changes in both DSM-5 and also ICD-11. So that one by one, we see that now we can have bipolar disorder with mood congruent and with mood incongruent psychotic symptoms. So the trials, which are largely based on DSM diagnosis or ICD diagnosis, they do not necessarily include patients or exclude patients based on the specifiers. The psychotic symptoms are now allowed in bipolar disorder. And in a typical Kraepelinian MDI, the psychotic symptoms were not considered to be part of the classical bipolar disorder. Also now full remissions are no longer necessary. We know partial remissions happen. We know there can be continued interepisodic subsyndromal or disabling symptoms. Family history is no longer considered while making a diagnosis, and we know other than a small subset, we don't find family history in rest of the. Earlier, it was in ICD at least, a single episode was labeled as acute mania, and it was only after a recurrence was established it was bipolar disorder. But now DSM and ICD both are aligned, and recurrence is not an essential criteria to diagnose bipolar disorder. And we know that euphoria is not a core or central feature anymore. We know irritable mania can happen. We know dysphoric mania can happen. So if we see last century, many decades back, what used to be described as an ideal candidate for lithium, now somewhere because of the nosological changes, we struggle to find that kind of response which was historically associated. And one reason why we find that about 1/3 are good responders, and another 1/3 do respond to moderate degree, could be because the lithium responsive subtype of bipolar disorder is a more homogeneous subtype of bipolar disorder, but not necessarily recognized in the classificatory systems. Now, this is traditionally what we know the lithium versus divalproate and carbamazepine. But if we look into each of these in more detail, of course, if family history of bipolar disorder is there, lithium should be preferred. Family history of lithium response bipolar should be preferred. Suicidality and family history of suicide, lithium should be preferred. Now, what about rapid cycling? We know lithium is less effective in rapid cycling. But compared to what? We know that lithium does not work as well, but that is compared to its own self, its own efficacy in non-rapid cycling cases. So this does not mean that lithium is less effective than valproate. And this is because there is no robust head-to-head comparison between lithium and valproate in rapid cycling bipolar disorder. And it does not mean that lithium should never be initiated in rapid cycling. At least in a recent meta-analytic evidence, about 60% of lithium-treated patients achieved at least 50% clinical improvement. So it's possible it may not lead to full improvement, but it may play a contributory role and can be used along with other agents, even in a rapid cycling bipolar disorder. The only exception perhaps is the continuous cycling bipolar disorder. So with no period of remission. So that is continuously cycling or ultra rapid cycling as it is called. But again, the caveat is in those cases, it's not lithium, but more or less none of the other agents also work. The good thing is rapid cycling is often a temporary phase and is not a lifelong diagnosis in a large majority of cases. So even in cases who have rapid cycling for a year or two may still respond to lithium better after resolution of that phase. Similarly, for mixed symptoms, as we shall see in the guidelines also a few slides later, overall evidence is also limited, not only for lithium, but essentially for all the agents, including second generation antipsychotics. In substance use comorbidities, of course, there seems to be a larger role for valproate compared to lithium, and so also with co-occurring epilepsy or migraine. Though cluster migraine, we know lithium works, but it's preferable to use an agent which covers for both the illnesses. In safety considerations and in the pragmatics of serum lithium levels, sometimes and that is one of the most common reasons, especially in the institutes which serve at the primary care level or secondary care level, that it's not always possible to have the logistics for lab monitoring, to educate the patient or to follow up the patient or have the family support. And therefore, pragmatics are one of the main reasons why lithium is underused. But if we see, largely lithium can be used or at least can be given a good trial in almost all types of bipolar presentations, though it is acknowledged that it works much better in certain subtypes compared to others. Now, this was a double-blind maintenance trial of lithium monotherapy for rapid cycling bipolar disorder. And here we see lithium monotherapy versus combination of lithium and divalproex. There were no differences, and this was up to 6 months. So there was no added difference when valproate was added. And this was the similar study up to 20-month double-blind maintenance trial. And again, there were only marginal differences between lithium and valproate in rapid cycling bipolar disorder. Lithium and its combination with lamotrigine, at least in this systematic review, which is a recent one, it lists the studies, though all of them had very low sample size, but it appears that in this limited way, with about 5 studies, close to 236 subjects, that combination of lithium and lamotrigine could be working significantly higher compared to either of the monotherapy. Now, coming to bipolar 2 disorder, lithium has much lower efficacy in bipolar 2 disorder, and quetiapine trumps the evidence. So lithium has level 2 evidence. And so to the extent possible, if the patient does not have contraindications, one can use the second generation antipsychotics as well. And as such, lithium do not have a clear superiority in terms of evidence. Though again, it is better than most of the other agents, and it is still a first line agent, even in bipolar 2 disorder as per CANMET guidelines. Also, we have to see that bipolar 2 disorder largely is a chronic depressive illness. The hypomanias are very few and far in between, and largely there are depressions which are often chronic and sometimes non-remitting. So there would still be a case for lithium in patients of bipolar type 2 disorder who require a combination therapy. But overall, type 2 remains understudied, and the number of RCTs are very small compared to bipolar 1, and studies are underpowered, largely speaking. So to overall summarize this argument, it is an undisputed front runner, and both quantity and quality of studies is better. And other drugs such as particularly quetiapine, olanzapine, etc., also have good evidence, but that evidence comes from enriched trials, and their tolerability concerns and metabolic burden, weight gain, dyslipidemia, etc., also could be problematic in the long run, especially in individuals who have family history of CAD or family history of other cardiac risks, etc. The second argument, of course, is the anti-suicidal properties. Up to half of the patients with bipolar disorder have suicidal ideation over the course of their life. At least 1/4 do attempt suicide, and 10% of individuals will die of suicide. So that is for every 100 patients with bipolar disorder, 5 to 10 will have death by suicide over the course of lifetime. There is also evidence that the attempts which are made in patients with bipolar disorder are more lethal. So that is the attempt to the completed suicide ratio is 3 to 6-fold less compared to the general population and compared to other disorders. So there is some evidence to suggest lethality is more, and it is a potentially preventable cause of mortality, and often suicide also tends to cluster in the families with multi-generational suicides, not being a uncommon history when we talk to the patients. And in that sense, apart from the mood stabilizing effects, the anti-suicidal properties would have to be considered, especially in those in whom a first degree or a second degree relative had a death by suicide. This evidence comes from huge number of RCTs, and with several thousand of patients. And the summary of it is that lithium was more effective than placebo in reducing the number of suicides and deaths from any cause, but there were no clear benefits in preventing the parasuicidality or deliberate self-harm. And so its role in borderline traits or borderline disorder, especially if it is comorbid, at least from an evidence point of view, remains rather sketchy. There are very few studies on that, and none of that is a randomized study. Lithium also tended to fare better, not only than placebo, but also compared to the other active comparators. And there were at least 15 different drug treatments which were compared in these RCTs. In unipolar depression, also apart from bipolar disorder, it reduced the risk of suicide. And in general, literature recommends that lithium should be the treatment of choice. It should be the first treatment unless the patient says no, unless there are any logistic concerns. Lithium should be offered for people with bipolar disorder who are deemed to be at risk of suicide, either because they had a past history or an imminent suicide risk, or because they had a family clustering. Lithium could also have a role in protecting those with unipolar depressions as well. Now, while most evidence seem to suggest the suicide prevention to be linked with lithium use, but at least there is one paper which I could find, and it's a very recent paper. It was only RCT data, and that seems to suggest that from RCTs only, the results are inconclusive. But we also have to acknowledge that the difficulty of studying suicide as an outcome or a suicide attempt as an outcome in RCTs. But there seems to be some contrary review paper which did not find the anti-suicidal properties from randomized studies only. Now, lithium in drinking water and suicide rates, there are more than 10 ecologic studies with a total sample across multiple geographical regions, which found a significant relationship between the lithium concentration in the drinking water and reduced suicide mortality in that population. And we find the odds ratio of 0.42, so about half. Interestingly, it is also dose dependent. We know the drinking water has lithium from the igneous rocks mostly, and it is from the also in the mineral springs also, it comes from the rocks. And across the various countries and regions, the amount of lithium, though all of it is in micro doses, often in microgram, but it varies, and there was a dose dependent association which could be statistically established with reduced suicide mortality. And there also appears to be a gender difference. Men were better responders, and they appear to benefit more from higher concentration of lithium in drinking water compared to females. And one reason which is hypothesized is that microdoses of lithium could be reducing the aggression and impulsivity, which also is more associated with males, male gender in suicide risk. So this is the meta-analysis from all those studies. So to summarize this argument, anti-suicidal properties are found in both unipolar and bipolar, probably due to reduction of impulsivity, but also because of better control of relapses. There is also reason to believe it could have independent anti-suicidal properties apart from its antidepressant and mood stabilizing action. And some support also comes from ecological data, though that requires further study. There are benefits beyond mood stabilization, and that should also be factored while why lithium should be used. And we know the neuroprotective and neurotrophic benefits. And also there are at least 4 to 5 studies which suggest a circadian shift to morningness, especially for the evening chronotype individuals. And that has led to better outcomes in general. The ones which are highlighted in red, the evidence is from human studies. Rest of the roles such as antiviral, immunomodulatory, etc., anti-aging, There is animal data to say that. This was the first paper in the year 2000 that was published in Lancet, which showed 3% increase in gray matter volume of brain. And it was a brief paper, but that generated interest. And over the next 2 decades, now there are at least 15 studies. And this meta-analysis confirms that it is a well-replicated finding that global gray matter volume was significantly larger in lithium-treated patients compared to lithium-free patients. Now, how soon are these effects noticed? The first study of Lancet, the effects were noticed as early as 4 weeks. But in majority of other studies, including prospective studies, the increase in gray matter volume was noticed as early as 8 weeks and also was found in people who had few years of lithium exposure. So both in short-term as well as long-term use, the effects, especially restricted to gray matter volume increase, have been noticed, and which is hypothesized to be neurotrophic and neuroprotective. The areas largely are hippocampus, amygdala, anterior cingulate, though there are multiple other brain regions as well. And some studies which have tried to look into such changes with other agents, especially valproate, did not find a similar increase with other agents. So it seems to be probably specific to lithium. There was no increase in white matter volume, but there appeared to be a better white matter integrity as seen in the DTI studies. Another set of evidence for neuroprotective properties comes from a reduced risk of dementia in lithium-treated patients. Now, the background of it is that the lifetime diagnosis of bipolar increases the risk for late life dementia by almost 3 times. And these 3 times higher rates are compared to the general population as well as those with unipolar. And more the number of mood episodes, they predicted a higher risk of dementia. But the treatment with lithium decreased this risk. And this is also shown in this forest plot from some of these studies, which we can see this diamond shape, it's clearly towards a lower risk for dementia. Also, similar to the suicide rates, lithium in drinking water appears, at least from some countries, to be associated with a lower risk of dementia for older adults. And this was seen for concentrations in drinking water which were more than 15 microgram per liter. And while the ecological studies still need more data, but it makes us think with the modern lifestyle, especially ROs extracting most of the minerals out of the drinking water, what kind of changes in terms of mental health do happen in societies? Data suggest that there is increased gray matter volume, reduced dementia risk, possibly lower rates of stroke, at least from one large-scale study. And this is a converging evidence from multiple kind of studies. Now, is it worth it? That's the last argument to say, is there a need to balance safety against efficacy or vice versa? Which one to give priority? Now, there are some points which I might want to make when safety concerns are brought ahead. The first is most of the safety concerns are from last century. And one very good example is the lithium registry that was actually established by Mogens Schou immediately after reports of Epstein's anomaly came. Now that lithium register got established in Denmark, Canada, and US and had about 200 to 25 pregnancies, of which 25 were found to have cardiac anomalies. Now 25 out of 225 was a pretty high number, but it was not a mandatory reporting. So this lithium registry falsely gave the impression as if Epstein's anomaly is much, much higher. And all that evidence is refuted in the last 10 to 15 years, starting from 2000 onwards. So there is a need to relook at the more recent evidence. Another example is also the CKD rates. While they are still more compared to Epstein's anomaly, as we shall see, but the recent evidence, uh, uh, while it suggests the rates are lower, but because of the historical scare, one tends to be more afraid of using lithium, especially if one has not used it during the training years. Also, we have to see the safety against the efficacy, especially the life-saving aspects of it. The safety concerns can be mitigated with preventive strategies like optimal dosing. If we optimize the dosing, keep the doses on the lower side during the maintenance phase, make it so that the peak Cmax is not, the peak of the serum lithium is not high throughout the day. So if we optimize the schedule and if we give proper education and mitigate some of the risks, it can be used. And there is no contraindication. There is no absolute contraindication, at least, except for acute renal failure and for acute myocardial infarction. So even with CKD, it's not, while one has to stop it, but the stop doesn't have to be sudden unless it is acute renal failure. So at least for the stage 3 CKD, one can take a time of at least few weeks and decide the course of action. And especially because there is no clear evidence of reversibility as such, and also because of the risks which are associated uh, with stoppage of lithium and subsequent relapses. So one can use in more or less all conditions except for very, very few absolute contraindications. We also have to see what are the alternatives and what is the safety data of atypical antipsychotics with QTC prolongation, with CV morbidity, and with the severe skin reactions which can be associated with lamotrigine, carbamazepine, etc. So the safety data of other agents also could be of concern. Now, in at least two major risks which are often talked about with lithium, one of it is the lifetime risk of severe kidney disease. And this, to some extent, is a realistic risk. Though the rates, as we shall see, that at least for almost a 10 to 15 years of use, it is not that much of a concern. And the concerns become more with 15 to 20 to 25 years of use. The 10-year cumulative risk of CKD for patients in whom lithium gets started early on, it was rather minimal. It was under 1%. It ranged from 0% to 0.7%. But once we start lithium above 55 years of age, the risk actually became several fold higher with 10-year, with almost a decade of use. So if one starts at 30 and continues till 40, the risk is less, as opposed to if one starts at 55 and goes up to 65. There is six-fold higher chance of CKD. The odds ratio is 6 with 20-year or more of lithium exposure. And the risk is higher if the pre-treatment serum creatinine levels are in the upper quadrant. So if we see 0.6 to 1.2, if they are already 1 or so in the pre-treatment, then it might be, and especially if the patient is older, it might be a good idea to look for other agents before going for lithium. The risk of nephrotoxicity is established to be increased if there are lifetime episodes of lithium toxicity. If there is a longer duration, as we already discussed, and higher cumulative dose lifetime. So these are the three important risks, risk factors, which can increase the rates of nephrotoxicity, and we can prevent all of it. We can prevent lithium toxicity, at least try to. We can reduce the cumulative dose exposure by maintaining the patient on the lower side. There was a twofold greater risk of impaired kidney function. Now, compared to non-lithium patient, the risk was twice. But overall, if we see in this study, 1/4, that is 25% of the individuals on long-term lithium had GFR, which was below 60. And in the short term, this study was about 5 years, no increased risk was found. but the risk increased after 2 decades, 1.5 to 2 decades of use. But we also have to compare these rates against the general population rates. About 9 to 10% general population rates are there for chronic kidney disease. So the rates with lithium, for example, in the previous study were 20%, but they have to be compared against the general population rates and not against 0%. So the time, yeah. So in the preventive strategies, look for creatinine creep, especially in the older adults. So ask the patient for a diary, and if there is a trend towards increasing creatinine, look for other agents. Switch to once daily dosing. So in the first week of lithium, we start from twice a daily dosing. But once the first lithium levels come after a week or 2 week or after first month, try to shift the patient to once daily dosing, especially when the titration phase is over. And if that dosing continues for decades or at least for most years, then the renal risk becomes lower. And the reason has to do with the peak levels. And then also lithium treated patients also have diabetes, hypertension, and a lot of other comorbidities, and some of which could also lead to CKD. So it's not necessary that all the contribution is by lithium. We also have to ensure adequate control of comorbidities. And one tends to avoid use of lithium if the patient is already a long-term diabetic or a long-term hypertensive, etc. There is some evidence to suggest that dose in the maintenance, especially in the older adults, could be around 0.6 or even a little on the lesser side. Though most guidelines propose 0.6 to 0.8 to be the standard maintenance range. And I think I'll take a couple of more minutes. The 12-hour, now this is important that once we maintain, because all of us get the serum lithium levels done, how to do it? We all know 12 hours post-dose, but these levels have been standardized. There was a researcher who worked with Morgan's Scow called Amdi Amdison. He did all the standardization work with serum lithium levels. The protocol is that blood should be drawn in the morning, 12 hours post, plus minus 30 minutes. But this standardization is for multiple dose regimen. It is not for once daily dosing. So therefore, in the titration phase, one tends to start twice a day. If one starts lithium carbonate 300, one gives twice a daily dosing till the first serum lithium or the second serum lithium levels are available. And a steady state condition should exist, so at least 5 days to 7 days. And skipped or extra doses have to be avoided. Also, the serum should be separated, preferably in less than an hour. And the reason for that is that if it is kept, lithium quickly moves into the RBCs if left unattended. And therefore, serum should be separated soon after the sampling is done. And there is a role for the usual monitoring. All of in Maudsley and most of the other sources suggest a standard monitoring. At the minimum, KFT and serum lithium levels, along with thyroid function tests, should be done periodically. There is some small risk for hyperparathyroidism, and therefore serum calcium levels can also be monitored. Now, in pregnancy, we have already discussed if lithium is being used, the fetal echo and frequent, along with level 2 ultrasound, should be done. And if we compare the risk of lithium, it still is very, very small compared to divalproate, which is around 10%. Though SGAs are much safer, and the risk with SGAs is almost close to the general population. The only exception being risperidone. So I'll skip these. So in sum total, lithium is the front runner, but it can also be a team player. It protects against suicides, protects neurons, And the safety issues which are often associated can be prevented, and one can try to manage it, but use lithium rather than shy away from using lithium. So with this, I'll end. I think the other part of it can be taken in the Q's and A's. But for an average patient with bipolar disorder, it is said that one needs reasons not to prescribe lithium rather than reasons to prescribe lithium. So at least it should be offered in the discussion. Even if you don't intend to use it, at least educate and inform the patients that there is one drug which can be considered in case the first drug fails or it does not lead to optimum efficacy. And it should always be on the table in the discussion. And the concerns, while they are there, but they can be managed with proper patient education and clinicians' motivation, of course.
Thank you. Thank you so much, ma'am. It was a wonderful presentation, very scholarly. I think if we had some more time, it will be even more better. So, some slide is left now?
No, we can skip that. I think the lithium, it's on its own. The second section of it is also the which is not anyways the intent for today, but the practical management and monitoring and managing some of the usual side effects like tremors, hypothyroidism, etc. But I think that
How much time will it take?
no, that that was not the intention for today. I think today we focus on why to use and when to use, and how to use wala part can be spotlighted at some later date.
So, ma'am, we'll request you to come at a later day because too many questions are there. We'll not be able to address all of them today only because a lot of interest is generated. So opening remarks from chairpersons, then we go to rapid fire questions because time is running out.
No,
Chair-
most of the questions were addressed during the presentation. So I think if there were any points not covered, they can be taken up. Like, can it be used once a day, and what is the renal toxicity? So all those things are covered. It was an excellent presentation, as you all agree. As Dr. Ramandeep mentioned, the people who have used it while doing training, they have that easy approachability of using it. They feel ease at use lithium compared to valproate. In fact, we were lucky enough to get trained in that area when valproate was not available or not used for bipolar disorder. And then we actually used it for quite some time and in quite a number of patients. The problem is now with the longevity of people getting into 80s and 90s, the continuing lithium and the presence of CKD in these patients because of hypertension and diabetes. And those patients, we need to reduce the dose and probably may need to stop after tapering. I think if there are any questions that were not answered, Dr. Alim, you can take them up.
Thank you. Thank you, sir. Aarti ma'am, any comments from your side?
Thank you, Dr. Raman. It was a wonderful session. I think we require a Lithium 2.0 session next because, there's so many other queries that are coming up. But I think lithium is a wonderful molecule and it's been time tested right from the 19th century. It's gone in its own ups and downs. It may be considered a poor cousin in the basket of the mood stabilizers as of today, but I think it's the most reliable one even today. And you've given a lovely presentation on that. There are a couple of questions which, one more point, Dr. Raman, is like about the seasonal episodes. We used to prefer lithium in our days, definitely, for the seasonal episodes coming in bipolarity. If you could add something to that, and then probably Dr. Alim and Dr. Vishal can take up the questions. Thank you.
I think in the classical profile, the seasonality is not mentioned as a preference for lithium per se, but we know at least in unipolar depression, including for seasonal episodes, lithium had some studies. For bipolar with seasonal specifier, I could not find any dedicated set of studies or evidence to say that lithium only works or more or less better than other agents.
Thanks.
Okay. Ma'am, I've tried to simplify the question, so I'll ask rapidly and with request short answers. Use of lithium in adolescents in lower age groups. How do you find it?
Lithium can be used it's approved for 7 to 17 years of age, recently been approved few years back. And while it's a tricky um it's a tricky situation. I always bring, if I am there with a 17-year-old or so 16-year-old, I always bring it to the discussion that there is one such a molecule, which if required, we'll use. I especially bring it to the discussion if the student or adolescent have suicidality. If the adolescent have a bua or a mama who has died of suicide, and there is already an attempt. So in those cases, I do bring it to the discussion, to the table. Now, it may or may not be picked. There are, and sometimes 16, 17, they come for the first time. You don't have enough repo. You don't know enough. They don't necessarily trust you in the first visit itself to start lithium. But it's always good to bring it for discussion. But if indicated, if the episode is milder, hypomanic, as we see in the prodrome, there are subsyndromal symptoms, there are milder manias. In those cases, one can go for second generation antipsychotics, especially if there is no depressive side to it.
So basically manic symptoms and suicidal symptoms.
If there is a high premium to the illness, pick up lithium. Well, there is no contraindication to pick lithium. Rest depends on
And
the
in elderly patients,
FDA approval is there for acute and prophylaxis both.
lowest age is
7 to 17.
7. And ma'am, in elderly patients, any special things to be kept in mind?
In older adults above 65, again, lithium have to be used with caution, especially over the long term. But if we see, actually, literature is much more, the second generation antipsychotics have much more notoriety or equally notorious in 65 years or older because of hypotension, for example, that is associated with quetiapine, because of sedation. So lithium, again, it can be used, but it depends on the risk benefit. But if we see, it has, the guidelines have recommended it in both pediatric as well as geriatric age groups.
Done, ma'am. And lactation?
Lactation, I have, while there are obvious benefits with breastfeeding, there are researchers with whom I know, there are people I know in Western countries who do use lithium and advise to monitor the infant's serum lithium level at 0.2 to 0.3, but I have not ventured into that. And to the large extent, because of the practical concerns, avoid using it. Literature does not say it's a contraindication. Literature says maternal सीरम लेवल्स के हाफ होते हैं या 1/3 होते हैं breast milk, and so it can be used as per literature.
In pregnancy, you said that Epstein anomaly is not a major thing now.
1 in 1,000. In general population, 1 in 20,000. So it increases the risk by 20-fold. So 1 in 20,000 से 1 in 1,000 हो जाता है.
So in a consumer protection code, will I be saved if a person is having it, or will I not be saved?
So if documentation is proper and if that can be produced, one can be saved.
Okay. Ma'am, regarding the thyroid
The
illnesses.
problem is there only documentation is often not there, or if it is there, it is with the patient. We don't often keep as good documentation. So that's the problem.
Thank you. I'm trying to be very rapid. Regarding the thyroid patients with hypothyroidism. So if hypothyroidism is there after start of lithium, then hypothyroidism. So should we continue? Should we not continue?
One should continue, because if one has picked lithium, there were good reasons to pick lithium in the first place. It's a difficult molecule. We should supplement and we should go. The only exception is if there is a rapid increase if there is a treatment resistance that leads to rapid cycling, then one would want to withdraw. But largely, in large majority of cases, they do well on L-thyroxine supplementation.
I mean, acne and psoriasis, when to stop?
One more thing to add to thyroid. Recently, I have also started, the thyroid volume is one more easy to do ultrasonography. So it's always a good idea if one center has it to do once a year ultrasound for thyroid. It's a quick 5-minute procedure.
In acne and psoriasis, ma'am?
In acne, acne in psoriasis, that's very rare. The exacerbations do happen. There is no evidence to say that they once activated, they don't always resolve. So, but in psoriasis, I avoid. For acne, it depends on risk-benefit analysis. And after first few weeks to months, sometimes acne resolve, and including with some of the derma treatments, which are topical, can be adhered to. And acne, unless they are a severe eruption in an adolescent or in a young adult, one would want to avoid for cosmetic reasons, but not a contraindication. If the patient doesn't mind it and is okay, I assure and later on reduce the dose.
Ma'am, you said morningness and evening chronotype. So 2 questions or 3 questions were there. What is morningness?
So that is the preference. Each of us have a certain preference of the daytime when the energy levels are the highest, when cognitive function is the highest, when one wants to do all the day's work. And there is an evening chronotype in bipolar disorder, which is associated with more nighttime eating, more calorie consumption, more internet addiction, obesity, poor outcomes. So there are at least 5 studies which say that lithium works through circadian or clock genes and shifts it from eveningness to morningness.
Okay. Ma'am, if we give lithium only once at night, what is the rationale? What are the good and bad points of it? Only once a day dosing. All the dose, 900, 1200.
So that is the preferred regimen. For all the long-term remitted patients, ideally it should be once a daily dosing. The only, as we already discussed, titration phase may one has to keep twice a day.
So
It's
why
good for
would,
kidney. It reduces the kidney risk.
thank you, wanted to suggest that. Okay, suppose a patient is non-compliant. So in such patients, if there are breaks in treatment, so lithium is not a good choice then?
So the literature on rapid sudden discontinuation of lithium leading to rapid cycling, there is no good evidence. Those were only case reports. But a person who stops, starts, anyways, is generally not a very careful person, is not too serious about the therapeutic. One can project that information to say that probably the therapeutic drug monitoring won't be kept. And there is a case report or a very uncontrolled kind of evidence that repeated stops and starts can lead to actually a worsened illness course. So one should avoid. Patient has to be committed if the patient has to be on lithium.
When to stop lithium when patient is having tremors? Any such situation?
So tremors, again, once daily dosing can help with daytime tremors also. And tremors can also be managed by reducing the caffeine intake. Other co-occurring medications can be optimized and adding propranolol, as we all do.
Thank you, ma'am. I have been very pressing. Apologies for that. Any other questions?
There is one more question I can see in chat box, which asks ki the 7 in 7-Up is lithium's atomic mass. Well, I also thought so because it's 6.9, but 7 in 7-Up is actually the 7 things, including lemon and other ingredients, and one of the ingredients was lithium.
Okay. Vishal bhai.
Yeah, just one question I found very interesting. Somebody said, can you use it in hypertension? I didn't let's say in Rania. When high blood pressure patients intake lithium, as we all know that salt is the best enemy for lithium. I didn't understand this question. That's why I asked it.
I think the volume is a little lower. If I could understand the question correctly, it's people with hypertension.
Yes, can high blood pressure patients intake lithium, as we all know salt is the best enemy for lithium? That's the question.
So if the hypertension is well controlled within first few years, as such, there is no contraindication with lithium use. No? Unless the hypertension is chronic, there is a risk of CKD. There is also CAD and or uncontrolled.
Thank you. But I think Dr.
Okay.
Raman will be with you again, I think, to continue this conversation.
Thank you. Vishal, your voice is very quite muffled. Ma'am, one last question regarding the anti-suicidal action. How potent is the anti-suicidal action? What is the NNT sort of thing if you talk in that terms?
I did not come across the number needed to treat, so I can't produce because. But if you are asking in terms of robustness of data,
Yeah.
the data is very robust. But the only thing is the data comes from multiple sources and not always. Randomized data is there, but it is also supported by indirect evidence and from, for example, ecological studies and lot of non-randomized studies. The problem of studying suicide in RCT model is because suicide or suicidality is usually not studied as a primary outcome in RCT data. So there is,
Okay.
but if you see the volume over last 40 years or so, there are a good amount of patient data from both randomized and non-randomized studies to say it has anti-suicidal properties. The first one to note was actually back in 1960s or so. But in 1980s or so, they were established to be independent of the mood stabilizing and antidepressant action.
So, ma'am, if a patient is on antidepressants, and so should we consider lithium only for its anti-suicidal action, not for mood stabilization? We don't want mood stabilization. For just suicide prevention, can we add lithium to antidepressants?
In unipolar depression?
Yeah.
Yes.
Unipolar.
Yes.
Okay.
One
So
should. It is a treatment of choice.
some questions keep
Even if in the short run, till the remission is complete, but also for the long run, both for unipolar and bipolar, there is good evidence.
Can you hear me now?
Yes, we can hear you now.
So I was saying, Dr. Ramandeep was an excellent presentation, and we need you again to continue this conversation. That's what I'm saying. Yes.
So we can have spotlight 2 on just the practical management, I think,
Yes.
which
Yes.
I felt also is important.
We'll be quite thankful, ma'am, because I'm trying to cover the questions because still they're coming in. Polyuria is there now. Cut-off serum
So
creatinine level.
that can be covered in the second one because
ma'am,
polyuria has a very stepwise approach.
okay.
And at least I had used amiloride, which worked very good. We had monitored with 24-hour urine, and amiloride can be used as a last approach, which is a
Thank
safe approach. And there are many non-pharmacological ways to manage that.
So I think Vishal bhai, we should end now because we already overshot the time. Any
Yes.
comments from chairpersons? Then Vishal takes over and says the vote of thanks.
We thank organizers for giving this opportunity to be with the today's meeting. I am a big fan of lithium, and now I become a fan of Dr. Ramandeep, her extensive knowledge and her excellent presentation, and my friends Vishal and Arati, and all the audience. Good night and thank you.
Thank you.
Thank you.
Thank you for having me, and also for running this Thursday musings very consistently and successfully.
Thank you. Thank you. Vishal bhai, your vote of thanks. If Aarti ma'am has to say anything.
Yeah.
I think it was a lovely presentation, and thanks to the organizers. And Dr. Raman, we'll wait for the Lithium 2.0.
Yeah, absolutely. Vishal bhai, over to you.
So, okay. Thank you so much on behalf of Thursday Musings team, on behalf of Dr. Fanpati, who's not available today, and Dr. Amrit, who's traveling to US. Thank you all. Thank you, chairpersons, Dr. Krishnan Mohan sir and Aarti for coming in and chairing session, and Dr. Ramandeep for an excellent scholarly presentation. We could see the passion you have for lithium throughout the presentation. The passion for lithium was amazing. I think it has kindled the hope in a lot of people that they'll use lithium, or they're becoming more excited about the lithium. So thank you so much. Thank you, Dr. Alim, for giving me this opportunity. I thank you all for joining in. I think we crossed more than 250 people at one time. The people were interesting, so that's very interesting. See you all next time on 191th episode. Good night, everyone. You can
Thank
close.
you.
Thank you.
Thank you, Vishal bhai. Ma'am, Lithium 2.0 is needed.
Yes.
Thank you.
Thank you. Thank you, Dr. Alim. Thank you, Vishal. Bye-bye.
Thank you. Good night, everyone. Good night. Ending the meeting now.